Good afternoon to you, our dear esteemed viewers. Welcome back to this week's episode of the Community Show. My name is Douglas Onen. I'm your host and moderator for today. Tonight, we shall be discussing the proposed national insurance scheme. Is it affordable for the common man? And that is the question that we pose today. So joining me to discuss this quite elaborate and interesting conversation is a panel of distinguished ladies and gentlemen who will help us put this into context. The persons joining me for this discussion, we are joined by a medical doctor by the names of Mr. Richard Kalungi. Mr. Richard Kalungi will also help us provide context to this tonight's conversation. Thank you very much, Mr. Richard, for taking time to join us in this discussion. Right next to Mr. Richard Kalungi, we are joined by Mr. Muhindo Francis Happy. Mr. Muhindo Francis Happy is also going to help us unpack tonight's conversation. And we are joined by Dr. Richard Kalungi. Right next to Dr. Richard Kalungi, we are joined by Mr. Muhindo Francis. And right next to Mr. Muhindo Francis, we have Mr. Akankunda Allen. But before we get into the conversation, let's just quickly get to know our panel so that we can begin the conversation. I'll begin with you, Dr. Richard Kalungi. Quickly introduce yourself so that we can have the other panelists do the same.
Thank you, Douglas. Good afternoon to our viewers and listeners. My name is Richard Kalungi, and I'm a medical doctor. I'm a public health practitioner, and I love to call myself a health advocate. I'm very glad to be part of the panel today discussing a very important aspect of health in the name of the National Health Insurance Scheme as it's being discussed.
Thank you. We're looking forward to having a wonderful discussion with you as well. Let us listen in from Mr. Muhindo. Just quickly, as a form of introduction, go ahead and introduce yourself.
Yes, good afternoon, viewers. My name is Francis Happy Muhindo Mwirima. I am a humanitarian worker and a peace and conflict manager and a community human rights advocate. I'm happy to be on this program tonight. Thank you.
Thank you. We are happy to have you as well. Mr. Akankunda Allen.
Good afternoon, everyone. I am Akankunda Allen, a public education student at Kampala University. I'm a writer, a female activist, a member of Girls and Mentorship Space, and I'm a team leader. Empower Youth Uganda. Happy to be one of the panelists today.
Thank you. Happy to have you here as well. Mr. Mike, are you with us? Kindly, if you're with us, please do unmute and go ahead and introduce yourself. Can see you're connecting, but okay. Once Muse has connected, we shall have him as well go ahead to introduce himself. But let us begin the conversation, and I would like to put context in tonight's conversation. The health sector in Uganda is comprised of both public and private health service, but it's largely comprised of the private health service. And this proposed national insurance scheme has been long overdue. But you also find that Ugandans oftentimes pay a lot of money to go ahead and receive medical services. And you find that the biggest percentage of this population uses their own money to go ahead and get medical services. So this proposed national insurance scheme is to hope that common person who possibly cannot be in position to get medical service at a particular time, but to have it at their disposal when the time is right. So I'll begin with you, Dr. Kalungi. When I'm talking about this proposed national insurance medical scheme, the question about affordability will come in. But even before we go into the question of affordability, just kindly give us an overview of the local person there who is following this conversation. Give us an overview so that they can understand what exactly is the national national insurance scheme. Dr. Kalungi.
Thank you very much, Douglas, and you've given us a very good preamble to this discussion. I want to start by saying that the insurance scheme or insurance policies are not a free pass to cheap or accessible health care. But before we go into that discussion, I wanted to start by showing us the various ways in which healthcare can be funded. You've given us a very good introduction around the providers, that is private and public. And in most of these countries like ours, the developing countries like ours, most of our people go to the public health facilities. But also know that there are other ways of funding care. Insurance is one of them. And we know that in our country, we have private health insurance schemes, which are largely taken up by those that are in a higher socioeconomic status. And this is defined by the percentage of people who are using it, which is less than 5% of the population. We also have social health insurance schemes in the communities. And sorry, that we have community-based health insurance schemes which are started by communities. For example, if you go to hospitals like Kisizi Hospital, if you go to Lacho Hospital, in the community, people bring up very small sums of money. It's not a private health insurance, but it's a community-based insurance. And this is also similar to what we call social insurance or social schemes. Now, the National Health Insurance Scheme would be part of the funders in addition to, so in part of the funding schemes or options, in addition to what I've talked about, in addition to donor funding, in addition to out-of-pocket, in addition to the private health insurance, and all the others, like I've touched on them. So the National Health Insurance Scheme, what we need to get very clearly, would not be a magic bullet to affordability. And also need to understand that affordability does not necessarily mean that something is cheap. It varies actually from community to community. And I liked what you said that will the National Health Insurance Scheme be affordable to the common man? So we need to define who is this common man and where are they found? And what are we talking about in terms of resources? So when we talk of affordability, it is both about income, but also about availability of those resources to that person who needs them. So the insurance scheme, by its definition, people come up and pool money. So all the Ugandans or targeted beneficiaries come up and pool money, a defined value or amount, and then this money is used whenever any of those contributors gets a medical challenge. But from what we see in the National Health Insurance Scheme as proposed by the Ministry of Health, it says that it will still, the ministry, first of all, the government will still continue supporting the government or public health facilities. But the Ministry of Health also says that the National Health Insurance Scheme will not only support curative care, because sometimes we only look at giving birth, being admitted in hospital, getting a test, but there's also the prevention side, the promotion side. So the Ministry of Health says that it will handle that as well. But to answer your question now, if we go into the real costs that people are going to, or the real values that people are going to pay, the Ministry of Health proposes that every person, this is in the amended bill now, the Ministry of Health says that every person who is above the age of 18, once this bill is passed and once it is implemented, will have to pay 15,000 Uganda shillings per month. And this is for everyone. However, they also go on to say, if the person is not 18, then their parents get to pay for them. And I've seen the Minister of Health sometimes stressing this point to say that perhaps it could be one of the ways that we're going to implement family planning. Because if a family has 5 children or 10 children or 2 children, their parents are going to pay for them. So that's how it is designed. Then they also look at the people who cannot pay, what you would call really the indigenous people, the very poor, the vulnerable, the least privileged. The indigents, they are going to pay 15,000 per year. Now, these figures sound really very small. And we also know that in the proposed amendments, the employers or companies are not going to make any contributions to any employee. So it's going to be as per individuals. So the point I wanted to make is when you look at these figures, they look small, perhaps to a person who lives in the town or a person who earns some money every week or every day or every month. But we know that there are many Ugandans who cannot afford this 15,000 per month. We know that there are many Ugandans today who sit at home and wait to die because they can't even afford to get to the public health facilities. We also know that in our public health facilities, even when they say that healthcare is free, we know that when you go in there, you have to buy gloves, you have to buy medicines, you have to pay for certain tests, you have to buy cannula, you have to buy a cannula if you're going to get treatment through the veins. So the National Health Insurance Scheme in its own does not catapult the health system into a blossoming affair or into a situation where it is now looking like the most advanced healthcare, the most accessible, or the most affordable. It needs to fit into a system that is already working. And what we have in our case is a system where people are no longer paying user fees because they were banned some years ago. It's a system where government cannot wholesomely support the public health facilities to run. It is a system where even the private not-for-profit hospitals are no longer affordable. It's a system where the private health facilities are very expensive. It is a system where the government officials, the MPs and the ministers and all those other kinds of people who work for us as leaders tend to use more of the facilities that are out of the country into what we call medical tourism. So I'm still skeptical that the National Health Insurance Scheme will catapult us into affordable and accessible healthcare because there are so many other things that we need to consider in terms of structure, in terms of provision of care, in terms of management of the scheme, in terms of real payment of the costs, and how the health facility structure in terms of private and public will now work together to deliver that kind of service to people. So we wait to see how it will run. We have the structure of how the Ministry of Health thinks it will run, but it will only wait to see how the implementation will be. Thank you.
Thank you very much, Doctor. That has been a very elaborate submission on, first of all, answering who is that common person. And that common person, you demystify it to be persons below the age of 18, persons above the age of 18, and then you categorize them in terms of vulnerability. But overall, the issue is the people who are, our population is one that comprises, according to Uganda Bureau of Statistics, that 41% of our population are poor people. So paying that 15,000 Ugandan shillings annually or monthly could be a challenge for most of the population in this country, which then takes the conversation to the issue of affordability analysis, which at this point in time, I would like to invite, I would like to call upon my brother Muhindo Francis, the next one will have Muzemai Kasoola to also give us his own understanding. But Mr. Muhindo Francis, issue is on affordability. So the question is, Doctor has highlighted that 15,000 is what is proposed that every Ugandan ought to pay to contribute to this insurance scheme. So the question to you is, how does the proposed scheme therefore define affordability for the common man? But then two, what percentage of income would that scheme require from an average individual? Is it really affordable?
Thank you very much. The scheme, the National Health Insurance Scheme, it sounds a very good initiative and good indeed. Looking first at the previous experience during the COVID-19 pandemic, to sell off property worth millions to get treated in a moderate hospital. And for those who could afford, of course, they could move out of the country. And there were very few, of course. Now, to a common man, it was between life and death. So, from the onset of this discussion about the health insurance scheme, it looks a pro-people kind of arrangement. And personally, I would love that we have a scheme of such a kind. But I am looking at the issue of affordability, and I'm critical on this. Affordability just like the doctors put it, the population in which we want to implement this is generally a poor community. And for your attention, it could be that a few people who are on WhatsApp, those who can watch television, those who can read, are the ones who know about this scheme for now. So that local person is not yet aware that there is even such an arrangement. And those who are not aware are even more than, or they are the ones who are even going to benefit a little more than those who are already aware. So the affordability part of it is what will actually define whether this scheme will be implemented effectively or not. We are looking at 15,000 shillings. I come from a community, Kasese and the Renzor sub-region, where in other places, people fall sick when Uganda National Medical Stores has released stock to the health facilities within their areas. When there is medicine, people flood. That's when they fall sick. When there is no medicine, people will not come over, meaning they don't have something in pocket, so they have to wait. So if, for example, this scheme was effectively implemented, it means people can walk in and access medical services at any point and at any time. But the very population we are talking about, the rural population we are talking about in this instance, is the very population that does not have the money. People are struggling to get what to eat on a daily, almost on a daily basis. And they also have to struggle to raise this money. So my questions were, my mind was rotating around the persons paying 15,000. One, how are we going to effect the payment? Who is going to be, collecting this money? How are we making sure the money from my family members, the 5 or 15 family members, comes to the general pool? That is one. Two, I was looking at who will be responsible. Yes, I'm a family head. I have 15 or 7 members in my family. And they are, so who will be responsible for getting this man and this and this and the other to bring it together and then pay it? Then how effective will this money be managed? Yeah, I have looked at an instance of how, for example, other schemes have been managed. You look at the NSSF. That is, for NSSF, it is a scheme and it is an obligatory kind of arrangement that workers have to pay by obligation. So there are no statutory deductions. But for this individual arrangement, who and how shall we effect the payment of the 15,000? Otherwise, I would personally feel that the scheme, if well managed, it is one thing that will help to address the healthy fragilities within the local population. And this is the 15,000 is an annual subscription. I don't know annually if indeed this is sufficient. I want to give a small little example on this. We have a hospital, it's a private hospital in Kasoola called Kaganda Hospital. They have a scheme where someone pays 3,000 shillings and you are able to access medical services. 3,000. We would go ahead and explore how such small schemes are working and how they are managing. Otherwise, I feel this is a good scheme, well managed, and if it becomes pro people before it is being implemented. For now, I beg to submit.
Thank you. Thank you very much. Mr. Abraham Muganzi, thank you for joining, but kindly mute. There is disturbing noises from your background. Thank you. I'll get to you though, but kindly please mute. Let's listen in from Mr. Mwirima Kasoola. Mwirima Kasoola, you joined us when we already we just began the conversation. Dr. Kalungi gave us a very wonderful introduction on how exactly the national insurance came about, and then about the affordability and benefits. And in his summary, he says that this, and provided there is implementation, then we shall have, you know, it will be good. But now is in line of coverage and benefits. Affordability still lies or gives us a lot of question marks. But let us push coverage benefits. So the question to you is, what specific benefit does the proposed national insurance scheme offer to the common man? But two, how does it compare to the existing insurance options in terms of coverage? Mr. Abraham, kindly.
Thank you, Drake. I hope I'm clear.
Oh, yes.
Thank you so much, Drake, for this good conversation. My question is the benefits to the common man, and two, the coverage compared to the current insurance schemes. Is that correct?
Correct.
Yeah, first and foremost, I want to say, yeah, it is very good that we should have such schemes to cover our health. Many countries, especially the advanced countries, have such schemes which cover their populations in terms of health and the other facilities. If this scheme is implemented, it can be a very good thing. There is no objection about that. I agree, it can really serve the population in covering health. You know, our minds were awakened to our health during the time of COVID, when people were to pay about 600 million, 300 million to have their bodies released from the mortuaries of the hospitals. It was quite embarrassing to a country, and everybody, I believe, thought that something must have to change, something must change for the better. What we are talking about looks rosy, indeed, but my worry is about the implementation. Why am I saying this? Is that this scheme seems to contradict the current position of the economy. It contradicts the economy. Why? Because we acknowledge that we have a very big population of people who are poor. And that's why we are giving out money through the parish model, a parish development model. We are also giving out money through the Myoga. The purpose of these schemes is to bring a big population, which is outside the financial sector, to also participate in making money. We are still testing these schemes. We have not done much about them. But we are now jumping to another scheme which requires a lot of money. So what do you expect after this? What do you expect after this? I look at something that is not going to work very easily. Uganda today raises something close to 25 trillion from local tax, local revenue. The other 50%, this is about 50%. The other 50% comes from foreign from foreign funding, meaning that the population has to incur a lot of debt burden to sustain their lives. Now, such a population is not walking, it's actually crawling. Now we are putting another burden on its back. I see you see a contradiction there. There's a very big contradiction there. Secondly, the population that pays tax in Uganda is a very, very small population of the people with some businesses. And these are big businesses. Actually, it has taken long for the Uganda Revenue Authority to widen, or government of Uganda to widen the tax base. And the burden now falls mainly on the people who have some money. This means that we still have a lot to do. But what we are doing is to come up with so many things at a go. And it will make it very difficult for us now to evaluate which one is working better. This scheme is certainly going to affect people's incomes, which are already low. So how does it really work? How does it can it be implemented? For National Social Security Fund, it is actually a provident fund. It is the mechanism is that it is forceful. You pay forcefully when you are working with some organization. The organization is obliged to deduct some money, also give you some money. They deduct your 5%, give you 10%, and invest for you. Now it is obligatory, but even compliance is not very easy. Now, what magic are we going to use? What magic are we applying to ensure that a person who's 18 years, a person who's not employed, a person who's looking for a job locally and not getting it, a person who's going to Qatar is going to contribute to national insurance, to health insurance. This person I'm talking about, the parent is in the poor bracket. How does it come? We are even giving money free to the elderly so that they can keep their lives. And this money doesn't come from local revenue. We get some of this money from World Bank. We get it from some donors. We are a country which is still staggering. So I find it a bit contradictory to say we are going to put another big burden to the population of Uganda when the current burden is big enough. That is how I look at it. Yes, as I said earlier, the benefits are okay. There are many. It's like asking somebody that now, what is the benefit of sleeping in a storage house located in Muyenga or located in Kololo, a bungalow, vis-a-vis staying in a grass-thatched house in my village? Certainly, I would say the former is better. The former is better. But how shall I reach Kololo when I am still in my rural area in Bulamburi, struck by poverty? Do I just go by magic, or something must be done? So the process should be gradual. I'm looking at this one going to shock our population. It will give them a shock. And the shock, what I mean by shock, it is going to be something that comes with a lot of heat on them. So my thinking is that, well, the population is good, rather the scheme is good, it is very rosy, it is very beautiful, but the affordability aspect may be a deterrent to implementation. That's my humble contribution to this.
Thank you very much, Mzee Micah. So that has been a very wonderful juxtaposition that you see. The scheme is wonderful. It is perfect. But now the issue is on the aspect of affordability. The benefits, ideally from the book, from the textbook, the benefits are outwardly very wonderful and very beautiful. But in your argument, that you see, we already have a budget constraint. We have a population that is poor. So the implementation would then be the issue, which therefore makes me invite in Ms. Akankunda Allen, then I'll get to Mr. Abraham to discuss the financial implications. But let me get to you, Ms. Akankunda Allen, on the issue of the implementation and on what Mwirima Kasoola brings into tonight's conversation, that the intended benefits of this national scheme are wonderful. But at the moment, in a country that is already financially strained in its budget, in a country that has a very large, very poor population, how shall we then implement this? Now, I wanted to bring this from the perspective of a young person, because I am aware that our country is majorly comprised of young people who are largely unemployed and do not even have money to contribute possibly for that 15,000, either monthly or annually. Mr. Kankunda, you're most welcome.
I beg your pardon. I've had like on the impact on young people or the impact on the population. I beg your pardon.
Impact. You are going to juxtapose the impact it has on young people, but then broaden it to the impact it will have on the population as well.
Thank you so much. So we must all accept that the access to quality health care remains a big challenge to many Ugandans, especially in rural areas and urban poor. Many Ugandans are struggling with high out-of-pocket health expenditures, which have forced most of them to sell their properties to pay for health care. This national insurance scheme will help the if it's effectively implemented, will help Ugandans to save for these uncertainties. Like most Ugandans would not save for sickness or these uncertainties, but if there is this scheme,
I love you so much, sir.
From medicine to the mayor.
So
yes.
The mayor is now the commander.
Put aside to help them save. Most of them will have money in terms of when it comes to these uncertainties, times of sickness. Like this is very much pronounced during the COVID times, where relatives of most people who contracted the virus had to sell off their assets to pay hospital bills, and this has been contributing to keeping most Ugandans in poverty. For example, if a person had a building in town that had been generating income for that person, and that person had to sell that building in order to pay for the health bills for the sick person, that person is going to be driven back to poverty, and we lose that economic generating activity, the assets. And then there are also some instances where some people have lost their lives because they cannot afford the huge out-of-pocket healthcare bill. Like a person stays home, like one of the previous speakers said, like a person stays home because they do not have money to access health centers and pay the health bills. They just stay home, and you find a person losing life in such instances. So to me, this scheme is of an advantage if it's implemented effectively. But our question is, will there be transparency? As into a common man, we've seen most of the government projects flopping because of the lack of transparency. They bring a project, and instead of benefiting the people that is supposed to benefit, it benefits the already rich people, or those who can afford taking themselves to hospitals. If 40% of the Ugandan households rely on the out-of-pocket expenses to finance healthcare, why wouldn't this scheme be of a benefit really? But our question still goes, are these services going to be given of quality? Aren't we going to find like there's going to be discrimination? You find in rural or in these hospitals that are in rural areas, the services are going to be of poor quality, and you find the high quality services are going to only be given to the hospitals in towns. This also remains a question to most of these implementers who are going to be taking up this scheme. Is there going to be sustainability through the reduced administration costs? Or is there going to be evaluation and accountability of how this money that we are going to pay is going to be used? So to me, I think it's a very positive policy or scheme to be implemented. But before these implementers do their work, they have to first look at the transparency, the accountability, the management, administration, and they assure the populace that the services going to be given are going to be of high quality. Thank you so much. Over to you, Drake.
Thank you. Thank you very much, Alan. And those questions you posed, I think we are going to answer them right now on the issue of accountability and transparency, which then makes me invite Mr. Abraham. Mr. Abraham, you joined us when we already began the show, but you're most welcome. And you can, maybe as you begin on your submission, you'll introduce yourself, and then you let the people know exactly who you are. But yes, you're Mr. Abraham, and people also want to know where you work. But my question to you is on the aspect of the financial implications, and particularly just two questions. That one, what impact could this scheme have on the financial stability of individuals? Because the proposed amount is 15,000 Ugandan shillings, and we earlier on agreed that our population is largely comprised of poor people. But then two, are there potential hidden costs or financial burdens for participants in this scheme? Mr. Abraham, you're most welcome. It looks like Mr. Abraham is facing technical issues. So I'll right now just take back the question to Mr. Richard Kalungi. Dr. Richard, my question to Mr. Abraham was the line of the financial implications. And maybe just allow me to repeat the question for you to help recap the question. The question is in line of there too, that what impact could him have on the financial stability of individuals? But then two, are there potential costs of financial participants? Doctor, you're most welcome.
Yeah, thank you very much. In public health, under the aspect of health economics, there's a very interesting term of financial catastrophe, which really refers to a point where people outspend their earnings or incomes in their endeavors to access or afford healthcare services. Now, we need to say, first of all, I like what Mzee Kasoola said, and what Mr. Muhindo said as well. It is something that is really tricky in our hands. It is something we need, but it's also something that we need to consider and dissect really well to see how it will work out. So we need, at the end of the day, we need to know that we need this. But like I said, no one particular way of financing healthcare is going to work. You need to have a bit of private healthcare. You need to have a bit of social health insurance, community health insurance, user fees. So it's usually a combination of all those. Now, when you look at that, it means that finances or funds that are going to support the provision of healthcare are going to come from various sources. And what the National Health Insurance Scheme now proposes is that instead of just sitting back and wait for government to give you everything in the hospital, make a small contribution. And the understanding behind this kind of system is that, first of all, people will start to take serious care of their health systems or their health, so that they're not is negligent, or they're a bit more careful of where they go and what kind of health care they receive. Like I said earlier, what we have today is a health system that is absolutely lacking proper regulation. So you have people going to churches and mosques for treatment, you have people going to herbal clinics and all sorts of run by unprofessional people in the community, and they are spending money in there. So what the National Health Insurance Scheme is proposing, that instead of spending 500,000 on a herbal concoction or spending 600,000 at a pastor's place or house, why don't you get all this money and use it for the benefit of all of us? Have the money for the mute, please. Yeah, so how do you get all this money and use it for the benefit of all of us? So it's not going to come easy. And looking at financial implications, it will certainly have financial implications on government, on hospitals, and on individuals. So the discussion here is largely around the individuals, because, like you said, 41% of Ugandans live on less than $2 per day. Abraham, please mute. So 41% of Ugandans live on less than $2 per day. What this means, these people are going to be the most affected. And then the other important statistic that you need to look at, 70% of Uganda's population is actually young. That means that the people who are actually above 18 years of age, who are going to pay for themselves, are the minority, which means that the people who are young are going to be paid for by their parents, by their guardians, by their relatives. So the burden is going to actually go to the smaller numbers of Ugandans. And we, like I said, we should not say it will not work. We should be realistic. We should learn as we implement, because the best way to learn on how a system will work is to start implementing it. And it's quite important that the Minister of Health has come up with a structure, has set up these rates, and we just hope that the Minister of Health will further engage practitioners, that's the medical doctors, the nurses, so that they understand it as well and their contributions. It will engage the providers in terms of private facilities and public facilities, know what their part of the bargain is. It will engage the insurance companies to know what their contribution is. And then it will also engage the regulators to know that if you talk of national health insurance in that country, you don't have a system where some people who are not actually regulated are also providing care, because that provides competition to the designated providers of health care. So in a nutshell and in conclusion, financial implication will be there, and they're actually supposed to be there. For you cannot eat your cake and have it when it comes to health care. Someone must pay for the health care. And what an insurance policy does is that it ensures that different players contribute into this pool. So as this conversation and many other conversations that are going to happen, the biggest question that we are going to solve is, how is it going to be possible to pay this 15,000 per person who is above 18 years? How are we going to identify those people who are indigent and they can't pay, so that they pay only 15,000 per year? How are we going to ensure that these people actually pay and they don't take off or run away like was the case of graduated tax? Because financial implication should really not just be about the 15,000 that people are going to pay. It should also be about the policymakers and the leaders and their commitment to ensure that our health system delivers a working national health insurance. Otherwise, if you have a situation where people are talking of national health insurance on one side, but still going to the US and Berlin and Nairobi for healthcare, then it will not work. We have seen what has happened in Kenya with their national NHIF, their national health insurance scheme as well. So it's not easy, but the best way to do it is to start, learn as we move, and then be as ethical and as committed as we can be in terms of ensuring that we achieve our targets or goals.
Thank you. Doctor, maybe just before you hang on there, I just have a question in line of government's perspective.
Hello?
Financial implications. I want us to understand what is the government's perspective. Then Mr. Muyinde will come and give us a public opinion. What is the government's rationale actually behind the proposed national insurance scheme? But then too, how does the government justify the financial burden on?
Hello?
Yeah, thank you very much, Douglas. I need to say that I don't work for government, but I'll attempt to answer the question. So one of the questions that we've been asking in our circles as medical practitioners is how government came up with the figure 15,000. We have not yet got a response, but like I said, something must start. So we must applaud the Ministry of Health and government of Uganda for getting us a starting point. And that starting point would be defining who pays what, how often they pay it, and most important, what it's going to deliver. So in terms of the policy, the Ugandans will be told what they pay and what they get on the other side. If I pay 15,000 per month, what am I getting in terms of health care? Am I getting vaccination? Am I getting treatment? Am I getting diagnostics? What is it that I'm getting? And then the other thing is, am I going to pay any more money when I go into hospitals or not? Then the other thing would be, am I going to get the same kind of care in a public health facility like I would get in a private facility? Can I walk into a Nakasero Kampala hospital just like I would walk into Mengo Hospital or Kagando Hospital like Muhindo was saying? So there are so many things that need to be answered. It is not like I said, National Health Insurance Scheme is not a magic bullet. It's not something that is going to get us from the low levels where we are to the top advanced levels, but it makes a contribution. It only needs people who are really people of integrity, people who are going to mean what they are saying, because national health insurance, just like technology, works with functional systems. If you don't have a functional system, there is no magic technology that is going to improve services. Have not proper systems on ground and proper leaders and proper providers, the National Health Insurance Scheme will also not provide any kind of magic. So the perspective of government is that this is a scheme that they believe will reduce catastrophic expenditure on the side of the citizens and local people, the common man, like you call them. But they also believe that it's something that will reduce the burden on government itself. Because today what we have is government spends less than 50% on our Ministry of Health budget. And the rest of the money comes from international partners, development partners, and donors. So what government is saying is that, part of this money could actually come from our Ugandans, our population. And like I said, when people know that they are going to contribute money, it may secondarily help them to prioritize where they are putting their money. If I've contributed my 15,000, then instead of spending a lot of money at a non-regulated facility in the community, I go into a facility. As long as that facility is going to give the care that I need, and it's going to remain true to the promise of the National Health Insurance Scheme. So the government, of course, is still discussing. These are not final details. These are not final policies, but the government at least has a direction that it's giving us. And so we wait to see the entire document of what will be agreed, both through Parliament and through Cabinet, and later when the President assents to the bill to become law. But also know that the civil society and medical organizations like Uganda Medical Association and the nursing organizations will all make contributions. And then the population as well, the community will also make contributions. So it's still a moving conversation, and we shall wait to see what happens.
All right, thank you. That has been
Drake, I need to come in here.
Yes, Mr. Abraham. Yes, we can hear you, Mr. Abraham.
Yes, I need to come in now. I've been waiting for too long. Yeah, now, good morning, members. I'm really sorry. I've had some technical issues, but now I hope I'm loud and clear. Now, answering the question you were saying, actually, the National Health Insurance Scheme that the ministry is proposing, it is something that is long overdue, that we have been waiting for a long time. Actually, it is one of the solutions towards our good health care. Now, you raised the question that how the financial impact of it on our citizens, or will the citizens really afford, or what would be the mechanism of collecting this money, and what will be the mechanism of using this money? Because there is collecting the money, and then there is the aspect of using it collectively so that people can achieve good health care. Now, we're looking at what the ministry is proposing, especially the amount of money. That is 15,000. Actually, to me, this money, when you look at, we need to look at the statistics clearly. There is what we call expenditure. When the Ministry of Health is making a budget, its annual budget for extending services to the people, there is what we call expenditure per person, depending on the population that we have in this country. Now, when you look at the last demographic or the last survey that was done, that was in the 2020-2021 financial year, it was estimated that our expenditure per person, or what the ministry budgeted, was $36 per person. But when you look at the recommendation from the World Health Organization or the UN, the recommendation is at $86. When you turn them into Ugandan money, $36 is 138,600 that the government is budgets to spend on each individual every financial year. But what is required as per the standards, the international standards, is $86. That is 330,000, 1,100 shillings. Now, when you look at the shortage or the gap that is between what we budget to spend and what is supposed to be spent actually, it is a difference of almost 200,000. So where can this money come? Where can this money come from so that it covers the gap so that our people can be able to access good health care? Now, when the government comes up and proposes the issue of health financing, or a national health financing scheme, where each individual is expected to contribute to 15,000, for me, I think this is a welcome move. Now, people were worried about this scheme and how it can be implemented. For me, I look at it as a very simple thing and how it can be implemented. I have a number of issues here that I'm going to put down on how this thing can be very, very easily implemented. Number one is that this health insurance scheme should be divided into two. One is that the national insurance scheme should be divided into two. That is implementation at the formal sector and implementation at the informal sector. At the formal sector, that means it will include the government employees, and then the private sector employees. This one, it is very easy because we just implement it through the institutions or the mechanisms that are established already, like what is NSSF is doing and what others. Then, at the informal sector, we should be able to implement it through what we call the community health-based scheme. Community-based health scheme can be implemented through one method. The one method which can help to implement this scheme and to make sure that these people get this money and everybody is covered. And those, because it will cover three sections. One, there are those people who cannot, even if you push them to which level, or even if you do what, they cannot afford this money. We all agree that there are Ugandans who cannot totally, completely afford 15,000 of this money. Then there is another category of people who can be classified as can afford to pay. These are the people who can afford, but who are there, complaining, we cannot afford, but in actual sense, they can actually afford. Those ones can be categorized in that manner. Then there are those who are determined by the community systems and what, that they can really afford this money. So the three people, now, the way we are supposed to do this thing is through what we call, we can use the health, the VHTs, village health teams, which are already established all over the country, throughout the whole villages. And then the LOC systems. The LOC system and the village health system, village health teams system, these two systems can sit together and then do a consultation with the Ministry of Health to determine the other three categories which I've talked about. The one, those who cannot afford at all, those who can afford, and those who are determined to afford, these three categories. And that can be done through what we call a nationwide socio-economic and demographic information data that can be collected throughout the whole country to determine the other three categories of people who can afford to pay this amount of money. And to me, that one can be done. It's very simple to do. When these VHT people, they already know the families which are really badly off to do, those which are in the middle, and those which can afford to do this. That is number one. Number two, how can this community-based health system ensure that our people, really, even the last person, gets the effective services at the health centers? Now, to me, I think this amount of money should be, there should be a committee, especially made of the village health teams and the LOC system, which can be able to ensure that each health center, the last health center at the village or at the parish or at the what, should be able to have the drugs. Because the biggest challenge that we have in our healthcare system is the drugs. And then what we call attention to patients. That is health workers attending to patients. Those are the two major challenges that are at the last health center level: the drugs and then attention to the patients. Then the health that system can also work within the health center, work with the health center to ensure that there are the referrals that go to the district and the regionals and then to the nationals, the system like that. Now, let me go to what the minister is saying. To me, the minister is using a language which is very unfortunate. When the minister was talking about this issue of bringing the issue of the 15,000, I think was using a language which is likely to discourage, or which is likely to get the politicians politicize this issue and fight it. Now, you cannot say as a minister that the reason why we are bringing this money is we want to make Ugandans responsible. That when Ugandans go to Mulago, you get.
Sabra, I'm going to kindly, as you summarize, because our time is fast spent, so that we can wind up the show.
Yes, I'm going to summarize this. The minister cannot say that when a Ugandan goes to Mulago, he misuses the infrastructure, everything, which are there. They destroy their beds, they destroy the what. That's why they are majorly bringing this money. That when they go to a private health clinic, they don't do that. Now that the reason why they are bringing this 15,000, they want Ugandans to own their facilities. No, this is not the biggest issue. The biggest issue is we want the services. The services that, for me, if I pay my 15,000, if I go to a health facility, and I should be able to be attended to as a Ugandan and get the effective health care services. Now, the proposal is from the other three categories. To me, I propose that let the other three categories of people be given cards. One, the people who are unable to pay, let them be given a white card, so that whenever they go to health center, they are identified through the mechanism that has been set up at the village level. Then, to me, the second category can be given a yellow card to know that this person is able to pay, but is also complaining that I cannot afford to pay, but is able to pay. Then the last category, which is determined to pay, that one by all means, can be given a blue card. So that when we are looking at our village setup and the household and the number of people that are within our village, we are able to know that out of 1,000 people that are within our village, we have 100 people who cannot afford completely. We have 300 people who can afford. And then we have 700 people who are able to pay. So that it can help us to identify how do we cover the gap of the other people who cannot completely afford. And then how does that funding, how can it be covered? Can we propose to government so that the government can top up the other funding of the who cannot afford? To me, that's what I submit.
Okay, thank you. I would really want to continue further, but what time spent? So I'll just quickly, in less than a minute to 30 seconds, I'll begin with you, Ms. Allen Akankunda, on your recommendations and concluding remarks. Then we can go to the other panelists. Allen, kindly give us your recommendations in less than 30 seconds and concluding remarks.
Thank you so much, Drake. I appreciate every panelist that has given out his submissions today. Yeah, the scheme should be, to me, what I conclude with on today's discussion, the scheme should be designed to address the needs of all citizens, including the poor, vulnerable, and marginalized groups. This is where corruption should be given a critical eye. And if we are to use VHTs or LOCs, I wish sure that these people are not going to favor their people like we've been seeing in other government projects, Semyoga and other projects, like a person who's a VHT has a favorite family and picks like the two people of those, like members of those families, and put them in the people who cannot pay. I think that one should be given a critical eye. And I also recommend universal coverage, comprehensive benefits, sustainable financing, strong governance, transparency, and accountability. And then partnerships and collaborations with these private insurance companies. This will help to leverage the resources, expertise, knowledge, and ensure that the scheme is responsive to the needs of all Ugandan citizens. I appreciate everyone who's listening in. I remain Akankunda Allen, the team leader, Empower Youth Uganda.
Thank you. Thank you very much, Allen. Mr. Muhindo Francis, kindly come in and give us your recommendations and concluding remarks.
Thank you so much, members, for the submissions. One, as we implement this scheme, we should be considerate that some Ugandans have choices to make. So they can either go for private or remain within this scheme. Two, we should be mindful as we implement that there are people who are natural traditionalists and they will not want to subscribe to such a scheme. Three, we should be able to learn from other engagements. And I was proposing that we need to pilot free money, but we this money at least in specific districts using such a money, and then we see how people pick up. The other one is that the enforcement should be done, because what happens if I don't pay? What happens? Will I be arrested and all this? So enforcement. Then we should also look at the experience of telecom companies. You buy your own phone, SIM card, but everything is tax. When someone realizes there is someone who is able to pay 15,000 of that. And lastly, there we have had free schemes, UPE, free medical services, and all this. What has gone wrong with free medical services in hospitals that we should opt for a healthy scheme? Is it that we have run out of money? So my submission is that let us be very sensitive while implementing this scheme. But to me, it is very good, because I've benefited from other private schemes. It would be good, but let us sort out how it becomes pro people and pro poor. Thank you.
All right. Thank you. Pro people and pro poor. Mr. Abraham Muganzi, kindly come and give us your recommendations and concluding remarks, and we shall last.
Yeah, thank you so much, Drake. My lasting shot or the recommendations are basically three. Now, the first one is that previously we implemented, that is in the 1990s, there was a system of cost sharing where everybody who went to any government health facility paid 500 shillings. Previous in the 1990s, and this worked tremendously. So can we look at that system, how it worked, what were its benefits, what were its challenges, and review, then see how we can learn from there, then implement this as we implement this issue. That is number one. Number two is that this, as we implement this issue, we need to do a lot of consultations. A number of people must be consulted. A number of institutions must be consulted. We need to do a lot of, for example, the religious sector is implementing a number, it runs a number of hospitals. And in these hospitals, majority of them have insurance schemes. So how do they implement these things and effectively? And you find them, they are so much affordable even to the last common person. So can we do a lot of consultations with these people so that we can understand before we come up with this thing to implement it in our solutions? Then the last one is there a possibility that we can do partnerships with a number of schemes that are already in place, especially, for example, like Save for Health, an NGO called Save for Health has a very good scheme where people are paying just 1,500 or 2,000, and it's working. So how are they implementing? How are they doing it? So we need to do a lot of partnership. Can we partner with them so that we can then bring, so that they can benefit? So thank you so much.
Thank you. Thank you very much, Mr. Abraham. Let's now conclude with Dr. Richard Kalungi. Recommendations and concluding remarks, and we can wind up the show. Dr. Richard.
Thank you very much, Douglas, Drake. It's been a very good conversation. I like what the other panelists in Allen, Abraham, Francis, and Mzee Kasoola have presented to the table in terms of their feelings, and which I believe are the feelings of the other people on ground. So in terms of closing remarks, I would say that the National Health Insurance Scheme is a good idea. However, what is important is to know how do we finally realize it? Because it's one thing having a very good idea, it's another thing seeing it deliver the results that we expect them. And I'll base this to what Abraham has said, or was it Francis, that we've had very many schemes, very many programs launched by this government, good on paper, but very terrible and pathetic on the ground. So in terms of recommendations and conclusions, number one, we need to engage the public as much as we can. And this public is segmented. There's public in the informal world, there's public in the organized systems, the employed people, those people in offices, and they need to be engaged where they are. Help them understand what the scheme will be and what their contribution will be. I don't think they have done as much sensitization and engaging and information sharing with all these categories of people. It will become very problematic to implement something on two people that didn't participate in its formation. Point two, we need to urge policymakers and our leaders and government officials to take the implementation and formulation of this scheme very serious. We have seen places where this scheme has struggled. We have seen problems with schemes in the past, especially when it comes to corruption and favoritism or nepotism. These are problems that can actually greatly affect its implementation. So we shall seek that the officials and leaders are very committed, are very respectful, and have a lot of integrity when it comes to implementation of this particular scheme. And then lastly, and very importantly, we need to have commitment from the providers. These are insurance companies, these are the private and public hospitals, these are the medical practitioners. There is no scheme which will work without the providers being in sync with what is being suggested. So if you say that someone is going to pay money, these people must know and what is being paid for. So it's going to be very important that we have more engagement, more discussions around the scheme before it becomes law and before it's implemented. Otherwise, it's a very good scheme. Let's remain optimistic. Let's share our ideas in the various fora that we have, and let's support it when it comes to ensure that we improve our health system and provide provision of health care in our country to avoid senseless death and to prevent preventable death and reduce catastrophic expenditure on the side of the Ugandan people and Ugandan citizens. Thank you.
Thank you very much, Dr. Mr. Muhindo Happy, Mr. Abraham Muganzi, Allen Akankunda, Kasoola in tonight's conversation. This conversation has been brought to the institution of we're discussing the possibility, we're discussing whether the proposed national insurance scheme would actually benefit the common man. Thank you very much, all the panelists, for putting into context tonight's conversation. It's been wonderful. See you again next week, same time, same place. Bye-bye. Take care. Thank you.